Welcome back. Today, we're putting on our medical detective hats. We're not just going to sit here and blindly memorize bugs and drugs. We're hunting down the exact diagnostic fingerprints you absolutely need to pass the MSRA. We'll be breaking down the pathophysiological profiles, those unique clinical syndromes, and, of course, the characteristic sputum features of pulmonary infections. The goal, so you can spot the correct answer from a mile away on exam day.
Here is our roadmap for this explainer. 1. The COPD pathogen hierarchy. 2. The cystic fibrosis evolution trap. 3. Atypical and severe pneumonias. 4. Some seriously high-yield exam mnemonics. And 5. We'll wrap up with 10 rapid-fire MSRA questions to test your active recall.
Okay, let's dive into Section 1, the COPD pathogen hierarchy.
When you get a clinical vignette describing an infective exacerbation of COPD, there is a very strict hierarchy of suspects you need to line up. Examiners love testing this. Your undisputed #1 most common pathogen is Haemophilus influenza. It's a gram-negative coccobacillus that just loves to colonize damaged airways, which is, exactly what we're dealing with in COPD. Coming in second, we've got Streptococcus pneumonia, the classic cause of community-acquired pneumonia, famous for that rust-colored sputum, alongside Staphylococcus aureus. And sitting right there in the third spot is Moraxella catarrhalis. So if the exam asks for the most likely cause of a COPD exacerbation, don't overthink it, go straight for H. influenza.
Moving right along to Section 2, the cystic fibrosis evolution trap. Cystic fibrosis is a massively tested area, but here's the catch. The causative organism for a chest infection completely depends on one single variable, the patient's age. It's a chronological shift. In childhood, so ages 0 to 10, the airways are pretty much dominated by Staphylococcus aureus. As that child moves into the early teens, Haemophilus influenzae takes center stage. But look at what happens in the late teens and adulthood. Pseudomonas aeruginosa takes over completely, causing a whopping 80% of adult CF chest infections. Seriously, if you don't check the patient's age in the vignette, you're going to fall right into the trap.
Next up, Section 3, atypical and severe pneumonias.
These specific pathogens leave unique systemic clues. Think of them like breadcrumbs scattered all over the patient's lab results and history. These are your high-yield buzzwords. If a vignette mentions a patient who just returned from a holiday, maybe stayed in a hotel with air conditioning, and now has pneumonia, paired with hyponatremia and deranged liver function tests, stop reading right there. The answer is Legionella pneumonia. On the flip side, if you've got a younger patient, say a university student with a walking pneumonia, who also develops target skin lesions, erythema multiforme, or hemolytic anemia from cold agglutinins, well, you are looking directly at Mycoplasma pneumonia. Now, sputum descriptions are literally a gold mine for MSRA points. If the phrase thick, dark red gelatinous sputum, or even better, currant jelly sputum pops up in your vignette, you're dealing with a severe necrotizing pneumonia caused by Klebsiella pneumonia. And here's the kicker. You'll almost always see this paired with two very specific patient profiles, either patients with excess alcohol intake or patients with diabetes mellitus, particularly when the upper lobes are involved. We definitely can't discuss structural lung predispositions without hitting this classic scenario. An aspergilloma is a fungal ball that essentially sets up camp inside a pre-existing lung cavity. Think of the empty spaces left behind by old tuberculosis or severe emphysema. So how do they test this? They'll describe a patient with a history of TB who comes in with recurrent coughing up of blood, hemoptysis, and the imaging will describe a mass inside a cavity that physically shifts around when the patient changes position. All right, let's move to Section 4, high-yield exam mnemonics. Let's wire these clues right into your memory for instant recall. For Klebsiella, just remember KLEBS. K is for Klebsiella. L is for lobes, specifically the upper lobes. E is for ETO, meaning alcoholics. B is for blood-tinged currant jelly sputum. And S is for sugar, meaning diabetics. And spaces, meaning cavitating lesions. Pretty cool, right? Now for Mycoplasma. Remember MAHM. M for Mycoplasma, A for atypical pneumonia, H for hemolytic anemia mediated by IgM cold agglutinins, and M for erythema multiforme. Literally the entire clinical picture wrapped up in a few letters. Now, to completely beat that cystic fibrosis age trap we talked about, remember this timeline. Staph, flu, pseudo. Staph aureus first in childhood, H. influenza second in the early teens, and Pseudomonas overwhelmingly dominating in adulthood. And when you actually need to treat that adult CF patient with Pseudomonas, just remember CIP, pseudo. Ciprofloxacin, Cipro, is your go-to targeted oral fluoroquinolone therapy. Okay, Section 5, 10 MSRA rapid-fire questions. We've built the foundation, now let's lock it in.
I'm going to read the question, pause for a split second, and I want you to lock in your answer. Ready? Let's do this.
Question 1. Think back to that hierarchy we discussed. The damaged airways. What's the undisputed number 1 pathogen? The answer is Haemophilus influenza.
Question 2. Spot those clues. A hotel stay, meaning water systems or air conditioning, plus those classic systemic fingerprints of low sodium, hyponatremia, and deranged liver tests. The most likely organism here is Legionella pneumophila.
Question 3. So the key here is piecing together that KLEBS mnemonic, alcohol excess, upper lobes, and this very specific gelatinous presentation. We call this currant jelly sputum, perfectly classic for Klebsiella.
Question 4. The crucial detail here is the patient's age. At 24 years old, they are an adult. They've totally bypassed the childhood bugs. That massive 80% dominance belongs to Pseudomonas aeruginosa. Question 5. Connect the dots using our MAMM mnemonic. The younger demographic, the target skin lesions, erythema multiforme, and the cold agglutinins. This is the walking pneumonia caused by Mycoplasma pneumonia. Question 6. Okay, you have a pre-existing space, an old TB cavity. Now there's a mobile mass sitting right inside it, causing the patient to cough up blood. That shifting fungal ball is an aspergilloma. Question 7. Let's run back to the very beginning of our CFT timeline mnemonic. Before Pseudomonas takes over in adulthood, the airways are colonized in childhood and early teens by Staphylococcus aureus and Haemophilus influenzae. Question 8. Recall our rapid treatment hack. When Pseudomonas is the target, you want your patient to take a sip. The antibiotic is ciprofloxacin. Question 9. Back to KLEBS again. We already know the E stands for alcoholics, but what does the S stand for when we're talking about patient comorbidities linked to the severe cavitating pneumonia? It stands for sugar, which means the answer is diabetes mellitus. Question 10, our final rapid-fire challenge. This directly relates to the H in our MAHM mnemonic. The IgM antibodies cause a very specific reaction in cooler parts of the body. This is known as cold agglutinin disease or cold autoimmune hemolytic anemia. Excellent work making it through that rapid-fire section. By organizing these bugs into structured clinical profiles, you've completely transformed a massive, boring list of facts into a system you can actually use on the fly. You know the COPD hierarchy, you know exactly how to avoid the CF age trap, and you have those mnemonics locked in. So, I leave you with this final thought. The next time a complex respiratory vignette pops up on your screen or a patient walks onto your ward, are you ready to spot the diagnostic fingerprints? Keep reviewing these concepts, keep testing that active recall, and you'll master these MSRA clues in no time. Thanks for hanging out and learning with me on this explainer today.